to put together some plans for 2018. They're here this evening, so I would I'll ask them to come to the table and have them assist with the presentation here. Let me know when you want me to.
Okay.
Yeah, thank you, and please introduce yourselves also.
Thank you, I will. My name is Rayanne Beaudry. I'm the Executive Vice President of the Horton Group. With me tonight, I brought Alex Beaudry. He's a colleague that also works with Horton. I have Deb Eklund, who is a clinical pharmacist from Servue Pharmacy, benefit manager, and Cherie Bowser from Servue as well. So any questions that we have as we go along, I think I'm talking loud enough to be heard on air, so that's why I'm not sitting at the table.
Yeah, and I want to warn you also, if you touch the screen, everything's going to go screwy. So
Okay.
you can point all you want, but don't touch the screen.
I'll stay back just a little bit.
Yep.
So one of the things that we were asked to do as we first got involved with the city is we wanted to take a look at where all of the costs were coming from. So when we did this, we wanted to look for medical loss ratio reporting. And what this is we took every class. So we have the active employees that are continually working here. We have the retirees over 65 who have Medicare as their primary payer in most instances. We also have the retirees under 65. We wanted to see where our costs were coming from. We always work with a rolling 12-month period of time. So at the moment when we did this report, we were looking at 11/1 of 2016 through 10/31 of 2017. So this is where this data comes from. And what we're showing here is for the retirees over 65. So this means that these individuals have Medicare Part A and Part B in place. They do not have a prescription drug benefit other than under the city's health plan. And you're going to see how that plays out. Their medical paid claims less reimbursements, and I'll explain what that means in just a second, were $1,106,219 for this group of people. And this group is 300 individuals that are as of the beginning of December. Less reimbursements means the city as a self-funded health plan has a specific stop loss. And what this means is there's a deductible on every individual or every belly button on the plan. That deductible is $275,000. When a claim gets over that, then stop loss reimburses the city's claim fund. We did have one retiree over the age of 65, Medicare primary, who had a reimbursement of $92,898 in June of 2017, and this was for a retiree over 65. So that would be probably a prescription drug claim, because they're getting very expensive these days. Prescription paid claims for this class, for these 300 people, $3,177,118. So of the total prescription drug claims for the city of West Allis, the total population, it's 5,777,000. So for 300 people have 3 million of that 5.7 million.
About 55%.
55% in this one classification. Fixed costs, this is what we pay Anthem, Symetra, which is our stop loss carrier, all Express Scripts for any of their fixed costs to pay our claims, to adjudicate the claims, network access fees. For this group of people is $400,017,612. So you add the total expenses for this group of people, $4,700,949.45. The total income. What that is when we take what the city's paying for the retirees, what the retirees are contributing on their medical premiums on a monthly basis, times 12, for those same 12 months, we're getting $3,448,704 from that group of people. This means that they have a loss ratio for that 300 people of 136%. So for every dollar the plan takes in for these individuals, we're paying out $1.36. As we go through the same thing for the retirees under 65, now here we're going to have more medical claims because they don't have the Medicare Part A and Part B as their primary plan. The city is primary on everything. Prescription drug paid claims, another $1 million. Fixed costs, $294,897.96. This group of people is 203 individuals. The total expenses then, plus the claims, $4,436,803.96. Total income for this group of individuals, so the paid premium on behalf of them and their contributions, $3,486,828. Medical loss ratio of 127.24 for for this group of individuals. The actives, so our active participants, 466 employees. This does not include the other bodies, so their spouses, their dependent children, etc. These numbers are just the employees or former employees. The active loss ratio is 96.84. Break even for the health plan is 85% medical loss ratio. That's break even. So we're running hot in all categories, but significantly higher in the retiree spectrum. Any questions, or does that make sense? Okay. So when we take that data and we turn it into a budget calculation, what you're gonna see here now is this was the initial budget recommendation that we were making to finance and human resources. We have a slightly different time period here. We have medical paid claims through 12/1 of 16 through 11/30 of 17. So we wanted to use the most recent data that we had available. So those claims for the city, now this is just medical and prescription drug claims, 15,349,543. Claims over specific, so over the specific deductible, in that time period is 151,321. That's what the city got reimbursed in stop loss at that point in time. Then we have trend. Trend is basically medical inflation plus taxes and just different things that we all have to pay at 6% annually. Now, what this means is we're using a 0.5% trend for each month. Trend runs from the midpoint of the period of experience to the midpoint of the period you're projecting for. So that's where we get 12 months at 6%. The projected claims then go from 15,198,000 to 16,110,116. This is an underwriting formula that goes back decades. We don't have any lasers. What a laser is if I have a stop loss deductible of $275,000 on each individual, what the carrier might say is, well, we'll have that $275,000 on all of the bodies that are on the city's health plan, except for, I'll use myself as an example, except for Rayanne Beaudry, she needs a heart transplant. We're gonna have a specific deductible on her of $400,000. If that were true, if we had any of those, we'd have an adjustment for that laser, that individual that's being separately underwritten. We didn't have any of those, so there's no adjustment there. So our expected claims are 16,110,116. We have our fixed fees. This is healthcare reform, the taxes that are due under that, health savings account contributions the city makes, the wellness and labor benefits, health risk assessments, medical supplies, other expenses that the city has directly attributable to the health plan, $289,400. Horton's consulting fees are in here too because this is part of the health plan budget. We have a $48,000 a year in our cost. The estimated stop loss and administrative fixed fee costs, over here we have all of this broken down for you. We have an administrative expense at $48.53. There's 988 bodies. That multiplies out to $46,883 a month. We have stop loss. Oops, I did it.
Touch it.
He did tell me not to touch it. Sorry. One more. There you go. Ooh. Okay.
No,
Sorry
it's
about that.
mine.
I won't touch it. Stop loss, we had a 12% increase in our current stop loss of the 275,000. That breaks down that way. We also have an aggregate. What an aggregate is it's an umbrella insurance policy that covers all of the claims under the 275,000. So we have protection at a certain level under there as well. So our total stop loss and admin fees are $1,171,615.80.
The only thing I'd like to clarify is all of the increase in cost to administration, stop loss, those are estimates. We do not have our renewal yet. So those are just assumptions that we're making. Those numbers can and probably will change when we get the renewal.
And this budget also is assuming we do nothing different than what we are doing today. And you're gonna see why that's really important in just about the next couple of minutes. So this is what the city is currently getting in income. So we look at what's the revenue stream. So it's the budgeted amount that the city pays toward the health plans, whether it's for retirees or actives, plus the employee premiums. We're right now, so we need $17,619,131. We're getting $15,075,144. Which we would need if we did nothing different than what we're doing for 3/1, we'd be projecting a 17% increase. Because we need $2,543,987 more to run the health plan if we did nothing different than what we're doing today. So what does that mean? Well, we knew that the city didn't budget 17%. We also know that we don't want to handle a 17% rate increase, so we went to market. Now, there's a couple things that in the marketplace we went to very specifically. We didn't want to change from Anthem as our third-party administrator. 2 years ago, on 3/1/16, the city moved to Anthem specifically to take advantage of its Blue Priority network and its affiliation with Aurora, which the city also has a good affiliation and a good relationship with. We don't want to change that. That was a brand new change. It makes a lot of sense. The claims are way down from that perspective, from the cost of an average claim. So we didn't change that. But we did want to take a look at marketing the stop loss and marketing the prescription drug program. So go ahead, Rebecca. One more page. This is just the backup information.
Okay.
So here's what happened with the prescription drug program. And I'm going to explain the math, and then I'm going to have Deb Eklund talk a lot more about the clinical things that go behind that. So Anthem, first and foremost, basically says you guys are on a program with Express Scripts, that is their current pharmacy benefit manager, that pretty much lets everybody do as they please. It's what's called an open formulary concept. I can have any drug I want as long as it's federally approved, but it'll go into whatever tier it goes into. We asked them if they could return some of the rebates to the city. Right now what's happening is they have given you what they say is a $15.71 decrease on your administrative fees with them, which is already high at $48 and some change, but they've given you a $15.71 decrease because they're keeping all of the pharmacy rebates. They're keeping 100% of that. But they said, well, we could, if you asked us, we could return 80% of those rebates. The total current drug spend, all three of the classes, so retirees over 65, under 65, and actives, is $5,769,764. They're saying there's no administrative fees to change to this program that they have, so that's zero. There's no additional per employee per month fees. We've spread this out so that everything is 100% transparent for you, so you're going to see how this works out. The number of prescriptions here for the 970 bodies that the city has on the 70 employees or former employees is 43,669. That's the annual prescription count. Total rebates that they're willing to return, so this is 80%, is $560. $560,550. They're going to retain $260,000 instead of adding more to the admin fee. They have a drug spend discount savings over current, so if we move to their new program, which really changes specialty, takes away some of the, they have more generic steerage, if you will. So the total cost, $4,769,312, as opposed to the $5.7, and we're looking at a projected savings over current of $740,000. So this is staying with Anthem but changing to a new formulary. Servue, one of the standalone pharmacy benefit manager that came back then, showed us 3 different kinds of formularies. The standard most closely matches up with what Anthem is projecting we should be doing. So if we take the standard formulary, which is unmanaged, and I'll have Deb explain these in a minute, we take our total drug spend, they do have an administrative fee. This is what Anthem is not charging you because they're keeping rebates or a percentage of the rebates. So it's $109,173. The additional Anthem per employee per month fees. So if we take away the stop loss from Anthem and we take away the pharmacy, we're conservatively estimating that the administrative fee will go up $20. It probably will be slightly less than that, but we're assuming the $20 PEPM. Number of prescriptions didn't change. The total rebates, and here's where you're going to see the biggest difference because Servue returns 100% of the rebates to the city. So it's $758,000 with their most open formulary. If we go to a managed formulary, it's $1,013,613, and if we go to what's known as the select formulary, we're at $1,368,700. What select is this is what's known as a closed formulary. There are some exclusions on that plan. No one will be medically impacted. Everybody has a therapeutic equivalent, and every class of prescription drugs is covered. It's just that there are some examples of certain new brand names that aren't included right away. So we're looking at a bigger total rebate on those. They retain none of the rebates. There's a bigger discount, savings over current. Some of this is coming from, to be in all candor, some of this is coming from a switch from a high-end brand name drug over to a generic or a lower brand name equivalent. But it's $537,706. Our cost is reduced to somewhere between 4.8 million and 4.2, and we're looking at savings over current of $1,565,393. There's or $1,002,000 or $955. There's additional savings that have not been factored in here for a couple of things that are called pharmacy trends. A lot of places are doing these. One is step therapy. Basically, I have to take a lower cost drug rather than the highest cost brand name when I get started on something to make sure, as long as I tolerate that, I don't need a more expensive opportunity. So the one I usually use as an example is if I can take omeprazole for my acid reflux, it's about $4 a month is the cost, rather than Nexium at $237. So we're going to start with the lowest cost drug in that class. Quantity limits, these are literally, I get 6 of my migraine injections a month, or 4, whatever the quantity limit is. I'm not getting a bunch of stuff that will get old that I have to throw away. I'm using the quantity limits. Dose optimization, I'm going to let the clinical pharmacist talk about, and then dispense as written. What we're seeing is, with a lot of the retirees, we highly suspect this is going on, they have no cost advantage to switch to a generic. So what's happening is they're taking a very expensive brand name drug because they don't have to change. So if I retired in 2007, for example, I had maybe 5% was the cost of my drug package. I don't have a copay, I don't have anything else. So if I'm spending 5% of a $300 drug a month, I'm only spending $15 as opposed to I could be at 0 or 4 if I took the generic. So we're not giving them an opportunity to make that decision. I am going to let you know that Horton is recommending that the city take a look at the select formulary, and I'm going to let Deb Eklund explain why that is for them.
Sure. Thank you for having me. So, as Rand introduced, I'm Debbie Eklund, the Director of Clinical Programs at Servview RX, a local pharmacy benefit manager that is just down the road here in the Research Medical Park. To set the stage, when we talk about a formulary or a preferred drug list, that's really what it is. It's a preferred drug list. It's one of the most powerful tools that we have in pharmacy benefit management to help drive prescribers and members to those products that really are the most clinically appropriate and have the best net lowest cost for the plan as well, knowing that you have a bucket of dollars that you need to manage closely so that you can continue to provide an affordable pharmacy benefit and access for your members. I think it's important to know how a formulary is developed. It's developed by what we call a Pharmacy and Therapeutics Committee, or a P&T committee. I don't know if you're familiar with the term or not, but that essentially is an independent group of pharmacists and physicians that we contract with, so they don't have conflict of interest in terms of working for or being paid by manufacturers. It includes specialists, pharmacists, ethicists, and oftentimes a consumer member as well to make sure everything, is staying above board. And first and foremost, what their role is to look at the clinical value of these products and to look across therapeutic categories to evaluate all the evidence that's available and determine really what, from a clinical perspective, are the most appropriate drugs to provide the most widest access to and the lowest cost to your members. And then, all other things being considered equal, they're making recommendations to a business committee, which then is looking at the economics and is looking to see if they can leverage some of these exclusion capabilities that exist from the manufacturers. And when I say exclusion capabilities, what I mean is that the manufacturers, we can contract with them that if we were to exclude certain products within a category and only prefer a certain number, that they will return higher rebates. And they will often also protect their price then for a period of time as well, to keep from raising prices. for several years. So that's essentially how drugs are determined to be on the formulary. And so, as Rayanne alluded to, there are a variety of types of formularies that we can administer. So we have what was listed up here as the standard formulary unmanaged, which we believe is very similar to what you're currently operating under, which essentially means that for every category that's not just a general plan exclusion, say fertility or something like that, that there is coverage at some level for every medication that's a federally approved prescription drug. And that also you're not employing any types of utilization management programs to help kind of drive appropriate use as well, which has become very important today with the rise of what we call specialty drugs. So these are these high cost medications that, again, you really want to make sure it's the right patient getting the right drug at the right time, the right place, and so forth. Then we also offer the standard formulary, which is that open managed, whereas you still provide a certain level of coverage across the board, but you do put in some of these programs like step therapy, quantity limits, and so forth. And then what the program that really today is becoming somewhat industry standards, because we can leverage significant financial value through these manufacturer exclusion capabilities, is our select formulary. So I think it's important to note again that we can leverage this value with only excluding less than 1% of all of the covered prescription drugs today. So if we look at a formulary file, there are approximately 7,000 drugs that are available today that would meet your general inclusions and your benefit. And less than 1% of those would be excluded under this new closed formulary, and yet you can see the return on investment is pretty high for that limited amount of drugs that are excluded. And so the areas that are targeted for these exclusions really make sense. So it's groups, categories where there's choice. So one example would be growth hormones. There are probably 8 different brand name growth hormones that are available today. They all run around $3,000 to $5,000 per month in plan cost, typically. They all contain the same ingredient. So the active ingredient is somatropin. They all come in a pen device that's ease of access for patients, and they all can be titrated to get to the dose that the patient needs. And so again, from a clinician's perspective, what's driving their selection is the formulary. So what's covered on the formulary? Well, it's brand X, Y, and Z. So you're still able to provide coverage of a growth hormone. You're just directing them to those that return the financial value to you. Other products we're targeting are those where we see, again, in categories that have choice. So you're not disadvantaging a member. They can still have access to that category and that medication, or things with really high price increases. So the example that's very prominent right now is around EpiPen. So are you familiar with the EpiPens? So there's another brand called AviQ. Are you familiar with AviQ?
Yeah.
Well, they don't have as much market share, right? Because we're all familiar with EpiPen, but not AviQ. So they've undertaken a play where physicians are sending in scripts to designated pharmacies that AviQ is contracted with. The member is told, you won't have to pay anything. The member gets their medication in the mail, but what they don't know is that the pharmacy is then submitting that claim to their benefit. And if the benefit does not have any management and program, that price for that AviQ for one box of 2 pens is running about $4,500 right now. That's their average wholesale price. Whereas EpiPen, which now has a generic that's made by EpiPen itself, so Mylan, who makes EpiPen, is now making the generic. We see this quite frequently. For the same box of 2, it's $300. So again, from the member's perspective, they're thinking, I'm just getting the drug free. But through something like the select formulary, the AviQ is excluded, and so we're moving them to the covered alternative on your plan is the generic EpiPen. The patient's still getting their EpiPen, but they're saving the plan, $4,200 just in that one claim example. And then I think the third piece are these brand drugs, which we've seen a pretty significant evidence on in the claim file that we saw, where there is an FDA substitutable generic. So the FDA has approved a generic that could be substituted at the counter unless the patient or the physician says that you have to dispense the brand. And so again, very significant cost savings there when you look at the brand versus the generic. And sometimes what's driving that again is copay cards. So the Lipitor might have a copay card that says you can only pay $4. Well, to the member, $4 is less than their generic copay of $10. So to them, they're saving money, but they're really not saving the plan money if they would switch to the atorvastatin, which would cost much less. The generic there.
So I think the two takeaways are we are looking very much at there is no medical impact or disruption. Every person that is taking a drug that's on the current formulary will have that drug's therapeutic class covered. We're just looking to exclude some of the higher cost models like in the EpiPen example. So they will all have a therapeutic equivalent and they will all have a means to challenge that therapy change if indeed they can't tolerate the generic or for some reason they've tried the EpiPen and they have to take the AviQ. They're allergic to a filler, they need some other methodology. So we just want to make it clear that this is not a plan change in our opinion, nor is it in our recommendation. And the reason I say that is we still cover generic and brand name drugs. We're just excluding some of the newer, or in some cases, some of the older therapies that no longer are cost effective or therapeutically effective as some of their other optional drugs. The other thing, Deb, just a quick 30 seconds maybe on dose optimization, because I think that's the one I didn't probably explain real clearly.
Sure, dose optimization is a program that is a type of quantity limit. So it's looking at medications that are dosed once a day, that's how they work. They work over a 24-hour period, that they're available in multiple strengths, and the strengths are all priced the same. So it simply becomes math. So a physician is prescribing 2 5-milligram tablets once a day instead of 1 10-milligram tablet. Since they're priced the same, they're paying double the cost the plan is. So it's just reaching out to the prescriber to say, is there a medical rationale for it? Were you aware there was a 10 milligram? And so forth. And I think just one last point is the transition tools that we have in place for when you are making a change in a preferred drug list. We have a whole toolkit that we work with the plan to notify members up front. With the claims file, we can send letters out. We can attend employee meetings. We can have not only our account team, we can have pharmacists available at these meetings, and so forth. And there's a whole, again, bunch of tools that we can help try to minimize any, fear of disruption or perception that there might be significant changes before they would occur.
And we would do that in the January open enrollment meetings just to make sure everybody has 2 months to talk to their physician. We tell them what to ask their physician. Here's the equivalence. Here's what our formulary change is going to be. So we want to use all the communication tools we have at our disposal. We've got, and I'm in the interest of time going to go through some of this really, really quickly. This is some of the background of going to the select formulary. So what's changing? This would all be information that if I, as an individual, for example, am taking Novolog, one of the ones down here, I would get a letter in January from Serviu saying, effective 3/1, Humalog is going to be your new drug of choice. Here's the questions to ask your physician, or here's the paperwork if your physician needs you to remain on Novolog for some reason. It's highly unlikely. Usually there's very little disruption or that people can't move. It's just a matter of using the different formularies. Where you see a lot of disruption here, 905 claims, these are all those brand name drugs that have an FDA approved generic or lower cost brand name. So that's the biggest thing here. And 905 is the claim count. That could be multiple, it could be a single individual taking multiple drugs 12 times a year. So it's per claim is literally a prescription. Here's a little bit more of the backdrop of how we separate mail service and retail. Also, there's a tool, a communication tool on mail order. If you have mail order right now for 7,000 scripts that we actually have going through mail order, we would send those individuals a notification. We're going to get a claim file so that Express Scripts will be allowed to transfer those mail order drugs right to Serviu. Go ahead to the next one. So what does that do? Honestly, this is how this changes the budget. So all the same stuff, and I'm just going to go really quickly through this. We also took a look at changing the stop loss. If we have 466 active employees on the plan, so if you'll notice, we have actually more retirees on the plan than active employees. When that is the case, and we're going to be talking about some other things for retirees over 65 in the last few minutes of my presentation here, but when that's the case, we feel like the $275,000 specific deductible is just a little bit more risk than the city should be taking on. So we looked at moving that. Sometimes when people look at specific deductible premiums, they're jumping over dollars to save dimes. So we want to manage the liability for the city. So we asked QBE of the Americas for a quote. Right now they are the most cost effective. So they gave us a $175,000 specific. Again, currently no lasers and no other challenges to that. So we have the same claims for that same 12-month period, 15,349. We would have, if we had $175,000 specific, we'd have an additional $200,000 that would have come back to the city in reimbursement. So it's $351,321. Our adjusted claims are $14,998,222. Here's the big net savings. If we had had the select formulary for over that period of time, we'd have saved $1,797,000 in rebates, discounts to the charges, and formulary management. Bringing our adjusted claims down to $13,000,002. Same trend, $13,993 after trend. We had no lasers. We had the same fixed costs. Adjusted for the change in the admin fee, you'll see that amount in red. That's the $20 extra that we talked about when we were going through the drugs. We're now looking at needing $16,188,000 instead of the 17. We currently are getting the same amount of money. This is a 7.38% increase. Significantly different. We've brought our rate increase down from 17 to over 10% with just a change in prescription drugs and a change in the level of stop loss. Now, one of the things that has come up before with the city, as I understand it, is the translation of how this 7.38% gets distributed over the parties. And we're going to talk about that next, but does anyone have any questions on this so far? So we are going to be recommending to the city in the January meeting that we're taking a look at the select formulary as a change and that we're looking at a change in stop loss. But this is what happens to the budget when we do that. Okay. And I'm going to let Peggy explain this.
It's even smaller.
So the next three spreadsheets look almost the same, except for on the top, you'll see actives, retirees, pre-65, and post, and they'll have different percentages. This first spreadsheet is the 7.38% increase, split out equally across every group of insureds. This assumes that every group of insureds is costing us the same amount of money, which we know it's not. We already have some differentiation in rates, which you'll see over in gray on the left-hand side. But so 738 was one option we could go all across the board. There's a lot of information. I know this is the first time you're seeing it. We certainly don't expect you to take it all in tonight, but it's certainly something you want to take with you as a point of reference for the future, because a lot of times we talk about what the retiree rates are and what the active rates are, and we try to compare them and we talk about percentages, but it doesn't really mean a lot, because with all of our retiree classes, you know, for example, if you retired in 2012, you might have a different benefit than if you retired in 2014. If you have Medicare, then you're paying a certain percentage of the increase, versus if you are pre-65 and you have you pay 100% of the increase. Of course, there's all of these caps in place, but this spreadsheet just kind of shows you the difference in somebody in that class with the minimum cost, the maximum cost, and the median cost. So some good reference points, but that is not what we're recommending. The next spreadsheet shows actives at 4%, retirees at 11.3%. Again, same information. We'd be happy to answer any questions on it, but the third one is really the one that says staff recommendation on the top is the one we're looking at. What that does is 5% increase for actives, 10% increase, 10% increase for retirees. We believe that's a middle ground. As you know, the Employee Benefit Committee is working on a long-term strategy. We believe that we can't pass this year, 2018, without taking some action, which is, again, the reason for the difference. However, when you saw the numbers of the utilization, I think you understand that we really can't go to the utilization numbers for our retirees. That probably wouldn't be realistic or palatable for them. But we do think that the 5% and 10% is reasonable in that regard. So again,
and there is precedent for this, as there already is a differentiation between 5 and 10% for the current retiree weighted average. So we think that this is just keeping in line with that particular.
Can you explain the second table? Not the, let me back up. The second to last page. The first one is showing if everyone's the same at 7.38. The last one's your recommendation. What is this middle table?
So the middle
Middle
one
set
is
of
just a
tables?
little variation, so the actives would be getting a 4% increase, putting
Mhm.
a little bit more weight on the retirees, 11.3%.
And was that to get everyone to pay into their class? Is that what you said? Or was that just sort of just a...
It was a little closer to the
To see
utilization,
edges.
right, so
Okay.
you saw the 136% and 127% on the utilization for the retirees and only 98% on the actives. So this gets a little closer to what the true rates would be calculated based off of those numbers. However, we also have to keep in mind that those numbers we were using, that's a 1-year set of numbers. 1 year does not a trend make, although we know that, you know, statistically, those are our higher cost users. So that's why we're recommending the 5 and 10.
And they're all set up to literally in the spreadsheet give us the same amount of what I call revenue into the plan because we need that $16 million to run the plan. And that has no consideration for reserves, nothing extra. This is just making the changes that we talked about. So this is again a one-time deal. It's a reset of the claims. The last thing that we're taking a look at, just in the, again, this is for future, we're gonna be talking a lot more about this when we meet again in January. We've talked about two things in the employee benefit meeting. The first is some of the pre-65 retirees have asked to what has been referred to as they wanna swing with the actives. So that question to me becomes one of the, it's kind of a challenge to take a look at. When you saw the different loss ratio amounts, and you look at what that retiree is asking for, what they're saying is we really want to spend less. So we really want to pay a lower premium, so we want to swing with the actives. What that does though, is it leaves the retirees who want to stay on a better plan, who don't want to swing with the actives because they're using drugs differently and they have a different drug plan, or they want to stay on the go anywhere you want plan instead of the group priority plan. It's allowing them to pay a lower rate without really changing their utilization strategy. It will not help the loss ratios. In fact, it will hurt them. So in order to keep the revenue kind of in these drivers the same and the weights the same, otherwise our pre-65 retirees, whoever's left, we're gonna be what's called adversely selected against. So we're gonna end up with a really dirty pool of people using a lot of claims, and then that's gonna skew the loss ratio for the pre-65 retirees. So we're not recommending that the city would allow that. It's our recommendation. The second thing though is we are looking at the post-65 retirees who are looking for opportunities to save money. We've done this in a couple of other clients that we work with. We've looked at a highly customized Medicare Advantage plan. And what I mean by highly customized is it might have no copays. It wouldn't have a donut hole in the prescription drug costs. So this is a highly customized, go anywhere you want that takes Medicare assignment, physician things. We don't have the quotes back on this, but we're gonna be looking to explore it so that in January we'll have more information for you. But if retirees took this Medicare Advantage plan, for right now, for example, you can see retirees where it's a couple, both post-65, they're paying roughly $1,400 a month, just to keep the math simple. The city pays 50% of that. In some cases, the retiree pays 50% of that. We likely could get that couple a great Medicare Advantage plan paying less than they were for less than their 50%. So the city could pay the entire premium. They'd have a very, very good plan, and it would come with all kinds of really cool bells and whistles, like, you know, silver sneakers for the post-65 so they can join classes. It's got, Medicare is really getting an awful lot of attention from the current administration as well as previous administrations. A lot more care and concern over those individuals, and it's a much more cost-effective option. They're still paying their Part B premium, but we'd make sure their drugs were very, very much in line with what the city is spending today. So we do think that that will be an additional option for savings for those retirees post-65 who are looking to do something a little bit better. Again, we feel from a legal perspective, this would keep in play with the collective bargaining agreements and the vested agreements that those individuals retired under, as long as we can make sure that nobody's medically disadvantaged. So that would be our goal. That is our goal in doing that. We've gone to a number of carriers. We expect to have those quotes in January, but that's kind of the last opportunity we're exploring, and we'll keep you posted on the progress as we move through that. I'm happy to answer any questions, and so is Deb or Alex.
Alderman Vitale.
Yes, thank you, Mr. Chairman. My first question is, what really the difference between Credo and Express Script to order your prescription online, you know, or through them? So now, right now we pay 17%, right, of cost. So by going to the other Serve-U, we'll go down to 10%, right? That's what I heard.
I'm not
Utilization.
Are you talking about specialty medications?
Yes, specialty, yes.
Where the cost savings come, there's a couple of different cost savings with specialty, and Deb or Sheree, please correct me if I'm wrong. The first is that the specialty pharmacy through a standalone PBM is going to structure where you get that drug, how it's delivered, all of those different things, and that's good. There's gonna come some savings through that. The second savings though to the plan is the amount of rebate that the plan gets in return for you purchasing that drug through their specialty pharmacy. So the individual, whatever the co-payment is, that would stay the same for the individual. It would just be a percentage of a lower cost.
Lower cost. And the Anthem, I mean, they're connected with Express Script, is that correct?
It's correct, but they're connected in the same way that Serve-U would be able to connect with Anthem. It is still a standalone. Anthem does not own Express Scripts. They do not. It's an affiliation. And in fact, Anthem is looking to get away from Express Scripts by 2020. So they're moving out of their contractual obligation with Express Scripts. So we're gonna have the same data feeds. Nothing is a new challenge with the new pharmacy benefit manager.
Very good, thank you.
All right, any other questions then? All right, well, thank you, everybody. This is something really to consider, and yeah, we'll be talking about this in the coming months.
Thank you, and I'm sorry I went over time.
That's all right, thank you. Okay, a motion to adjourn.
So moved.
Second. All in favor, say aye.
Aye.
All right, we're adjourned. Thanks, everybody.
So today there wasn't a quorum, so we just